For those of you who haven't met me before, my name is Peter Shaw. As you can tell, I am not from Brooklyn, New York, and spent most of my life in the UK. I trained at Charing Cross Hospital many years ago. Ended up for my sins as a GP in Maidenhead, looking after Maidenhead Rugby Club for about 13 years. And then for some reason ended up in the United States, which is a total other story completely. So anyway, Eugene's asked me to talk today. This is a similar presentation to the one that I did at Toby a few months ago. I've adapted it slightly since then. One thing I'm not going to do today is talk about DUROLANE. I'm going to leave that to others afterwards, and I hope you'll forgive me for that. But my involvement in hyaluronic acid has really been since it was first introduced into the UK when we were using Hyalgan, and this was in the mid-90s. And I've really been interested in it ever since, and somehow I have ended up at Bioventus, where of course in the United States we actually have 3 hyaluronic acids, a single, a triple, and a 5-dose product. But of course DUROLANE is the one that you know in the UK. People ask me why I still want to be involved in hyaluronic acid, and one of the reasons is I think we've got it wrong all the time, really, since they were first introduced, and I'll explain a little bit more about that. I do feel that if these were new products coming out now for the first time, firstly, they would not be approved as a Class 3 medical device or as a medical device, and secondarily, I think we would be promoting them on their disease modifying properties. And I firmly believe, and I'm open to challenging on this, that if used in the right people at the right time, at the right stage of the disease, that these products do have at least some disease modifying properties. You may ask me my reasons for that, and really it's based on the fact that these products have the majority of them, not DUROLANE of course, but the majority of them have an extremely short half-life of maybe 3 to 5 days in the knee joint. And yet the effects of the products go out 6, 8, maybe even longer months. And something else is happening other than just a biomechanical effect, or as people call them, a bit of lubrication and cushioning within the joint. Anyway, I'll get off my soapbox now and really go through a few of my learning objectives for this. The first and most important thing from my perspective is that we identify the appropriate patients to treat with hyaluronic acid. I'm then going to do a bit of differentiation between the available intra-articular treatments for OA knee. There's a lot of newer clinical evidence on the use and efficacy of high molecular weight HA versus low molecular weight HA, and perhaps deepen the understanding of where hyaluronic acid fits in the treatment paradigm when it comes to knee osteoarthritis. A little bit on the biological and possible disease modifying effects of hyaluronic acid, look a little bit more at their mechanism of action, and some of the maybe newer treatments for OA knee. It's a good time to be reassessing our treatment of osteoarthritis of the knee, especially in the light of the reluctance of patients to go and visit doctors, and in many parts of the world, a huge delay and sometimes a cessation of elective surgery. And if there's anything that we can do to keep these patients out of the hospital and delay the need for that first knee replacement, then I think we're doing our patients a lot of good. Now, one of the things I hate when people do presentations is they dredge up papers that were written and produced even before I was born. So what I've tried to do in this presentation is restrict the use of clinical papers and things that have been written to the last 3 years. And I think all of the papers that I'm going to quote, and I'm more than happy to share these with you afterwards, have been published since 2017. So my next sort of questions to you, and these are questions I ask myself almost every day, about hyaluronic acid, is were they actually the first true D mode? We always say that the holy grail in orthopedics and osteoarthritis is to find that first disease-modifying drug in osteoarthritis. We all know that the first DMARDs have now become multi-billion-dollar products in the world of rheumatoid arthritis. And with the increasing numbers of people suffering from osteoarthritis.
Looking at it, how big the lead.
Hello? Did someone have a question there? No. Okay. I also think we've got it wrong for a long time. We've done the wrong sort of research. A lot of the clinical trials have had either neutral or negative results. And when you look at how the trial was conducted, and we were as guilty as anybody in that. You know, some of the first trials on DUROLANE, half the patients had effusions that weren't removed before treatment. Nearly half the patients in one of the trials had KL4 disease, which of course greatly changes the way the results of these trials come out. So that's another question. The next question is, and we'll look specifically at this, is which patients will actually benefit most from hyaluronic acid, because that research has been done. But when you think about it, it's those patients who you would always have expected to do well with a product like this. And that's people with the mild to moderate disease with moderate to severe symptoms who are a sort of younger population as opposed to an older population. And then look at actually which patients get HAs, because there's a vast difference between those that should be getting them and those that are actually getting them, which is why the results, I believe, are not always as good as they should be. And then the biggest question, and this really comes from somebody who started their life in orthopedic surgery at Charing Cross and ended up in general practice, is I'm a great believer that the people who actually see the patients who will most benefit from hyaluronic acid, certainly in the UK, I would think are all in primary care. In the US, it's more people who are non-operative, sports med. Primary care in the United States tend to be very de-skilled, and I can say that because they're not listening, but they have a great reluctance to do anything invasive, and finding those GPs over here that do intra-articular injections is a bit like finding teeth in chickens. So, and the other question is, are we actually promoting to the wrong customer base? And I'm going to look a little bit now at the, the treatment paradigm that we've had for a long time, because if you think about it, the treatment of osteoarthritis really hasn't changed. Certainly hasn't changed over the last 35 to 40 years that I've been in clinical practice and doing it. Is, the only new things are perhaps some of the newer intra-articular things, and of course the surgical treatment has changed a lot. But ultimately, all we're doing in these patients is treating a symptom. Patients come in with pain, and that's what we treat, and that's the basis on which we tend to reassess them, is how they're doing with regard to pain and function. And that I may be speaking now from across the Atlantic, but the decision to operate on these people with regard to knee replacement is usually based here on the fact that their pain is no longer controlled, and not the fact that they have great radiological progression of their disease to the point where they actually need knee replacement. There's a lot of evidence that certainly in the United States, people are getting knee replacements both at a younger age and also at an earlier stage of the disease process. And this is partly because a lot of the treatments that we would like to give people for pain relief are either not approved or not reimbursed. And that is in particular, hyaluronic acids are a legacy of that. And the Academy of Surgeons have a lot to blame for when it comes to that. But if you look at this table here, is really things haven't changed. You'll notice that I haven't put opiates on here, and this is another one of my soapboxes. I really think that opiates have absolutely no place in the treatment of osteoarthritis. They do absolutely nothing for the disease process itself. They create a population of people who are addicted to opiates, and all the evidence shows that people who are on opiates prior to knee replacement actually take more opiates after their knees replaced than they did before. A little statistic here, in 2019, there were 90,000 deaths from opiate overdose in the United States, and over 70,000 of those were prescription opiates, not just the ones that were bought illegally. So the AAOS in 2013 issued their guidance, which was very negative towards hyaluronic acid. And as a result of that guidance, a lot of payers in the United States and a lot of people around the world have either stopped coverage of hyaluronic acid or made it difficult for patients to get it. Now, even as we speak, the AAOS are revising their guidance, and they approached me a couple of years ago to ask for all the recent clinical papers that have shown that HAs, when used in an appropriate population of patients, are actually beneficial. And we hear that they may well be changing their guidance. And part of the reason for them doing this is they realize that 95% of their members don't actually follow the guidance that they gave in 2013. So something that I did earlier this year is we looked, this I did with really as a result of the rheumatology, the ACR guidance, which came out in early 2020, which was again, and for the first time, and it surprised me coming from a rheumatology population, is they were actually negative towards hyaluronic acid. And what we thought we'd do is we'd look at all the guidance that had been issued on OA knee over the last 17 years. And what we found is that there was a preponderance of guidance which was positive towards both intra-articular corticosteroids and also intra-articular hyaluronic acid. And there was very little guidance, albeit from people with a strong voice, against HAs. And the overall trend was very positive towards hyaluronic acid and also towards intra-articular steroids, as you will see from this chart. This is just a chart from the paper, which is hopefully going to be published in the next few months. It's been submitted to the American Journal of Sports Medicine, who often do issue guidance on this and have published papers such as the Trojan paper recommending HAs for AMSSM guidance. But those three outliers at the bottom are the American Academy of Orthopedic Surgeons and the College of Rheumatologists. And really they don't conform to what current clinical practice is. So what I've then done is I've looked at something called the Osteoarthritis Initiative, which you may have heard of. This is a multi-center 10-year observational study sponsored by the NIH and not by industry in any way. And the goals of this were really to provide resources to enable a better understanding of both the prevention and treatment of OA as being one of the most common causes of disability in adults, not only in the States, but around the world. The first paper that came out from this was the Appropriate Use Criteria, which was published in 2017. And it was the most comprehensive assessment of appropriate use criteria for hyaluronic acid. And they developed AUC, appropriate use criteria, for 17 different clinical scenarios. In one scenario, it was deemed that they were inappropriate. In 10, it was uncertain. And in 6, they deemed that it was appropriate. And I've just highlighted the 6 over the course of the next 2 slides, but this is a great paper to look at. Because the panel of people who wrote it, people that you would recognize their names and respect their opinions, and also the fact that there was no industry sponsorship in this at all. And really it comes back to what you would expect is the people who will respond best to hyaluronic acid are those people with mild to moderate disease, so KL2, KL3 disease, who have moderate to severe symptoms, because ultimately that's why they go and see you, is because they have uncontrolled symptoms or their ability to function in their normal daily life is affected by that pain or loss of function as a result of their osteoarthritis. And I'm not going to read through all these because there isn't time, but I'm very happy to share these slides with you and also the papers afterwards. And again, this was the moderate group. So it was basically the same patients, the KL2, the KL3 patients who will respond to it. And then I was at the, actually this was the Academy of Rheumatologists meeting, ACR meeting in 2017. And this was a poster that was subsequently published as a paper. in arthritis research and therapy, which was again looked at a similar database of the same people, which really identified again those patients with radiographic osteoarthritis who benefit most from receiving HA. And it's, as I've said before, younger patients, mild to moderate disease, moderate to severe symptoms, who at the start of treatment have a greater medial compartment cartilage volume. And this has been borne out by all sorts of other papers since, and happy to share those with you. The next question we always get saying is, well, all HAs are the same. Well, all HAs are very, very different. There are now 17 hyaluronic acids on the market in the United States, and not a couple of them are the same, but they're the same product called by a different name. But ultimately, they are all very different, whether they're unmodified or modified. This used to say cross-linked or not cross-linked, but the makers of Hymovis claim that their product is not chemically cross-linked, although it is cross-linked. So we had to change it. But you know, we have normal healthy human hyaluronic acid, which has a molecular weight of around about 5,000 to 6,000 kilodaltons. Sorry, kilodaltons, 5,000 to 6,000 kilodaltons. And then there's the unmodified ones that are linear, single chain, non-cross-linked, that are either avian or bacterial. And then on the other side, we have the modified HAs, which are cross-linked by some process. Really, you know, Synvisc and Synvisc 1 are the same product. It's just 6 mils of Synvisc in a syringe as opposed to others. Monovisc is a much lower molecular weight. Gel 1 have never reported their molecular weight. And then DUROLANE, which has a molecular weight in excess of 10 to the 12 kilodaltons. So just a quick look at perhaps the biological effects of intra-articular hyaluronic acid. And this was a paper that was published earlier this year in Comprehensive Treatment of Knee Osteoarthritis, in fact, very recently in May. And it looked at really the biological effects of intra-articular hyaluronic acid. And this is something that we've known for a long time, is that if you inject synthetic hyaluronic acid into a joint, it actually stimulates the fibroblast-like cells in the synovial membrane to start to produce good quality HA again. I excluded this paper because it was published, another paper because it was published in 1986. But as far back as 1986, we know that if you put synthetic intermediate or high molecular weight HA into a joint, you actually start to produce good quality HA again. Because as I'm sure you all know, is that during the disease process, you get a natural breakdown of the inherent high molecular weight HA that we normally produce down to low molecular weight. And high molecular weight HA has anti-inflammatory properties, whereas low molecular weight has pro-inflammatory properties, which may be another reason why these products that we use now have a more biological effect, because what they're probably doing is stimulating those cells to produce high molecular weight HA, which then continues for the lifetime of the cell rather than the half-life of the HA that we're putting into the joint. So HA does work in other ways. We know that it increases the viscosity of articular fluid, it decreases the oxidative stress, inhibits phagocytosis, and also acts on nociceptors by inhibiting and blocking stretch-activated mechanoreceptors. So by all these processes, we're actually having more than just a biomechanical effect in the knee, we're having a biological effect. Now, in the last few years, there have been a number of papers that have come out in favor of high molecular weight HA as opposed to low molecular weight HA. This was a paper published by Andrew Konkoff, who's actually a rheumatologist out of Los Angeles, in JBJS Reviews in 2019. And the conclusion of this paper was that high molecular weight HAs have a greater relative effect compared with both non-selective and COX-2s, NSAIDs, and other treatments. And again, this was looking at the MCID, so the minimal clinically important threshold. As a result of a payer stopping coverage of HAs in the United States. The Arthroscopy Association of North America wrote a very good letter in response to Anthem, who were the payer who stopped coverage, really in giving them all the evidence supporting the use of high molecular weight HA in appropriate patients. Unfortunately, Anthem ignored the letter, but everybody else has used it since, and it actually does carry a lot of weight when you're actually supporting high molecular weight HA, because the letter is extremely well written and well referenced. Just another thing supporting HAs is that it's now known that if you use HAs, you will actually reduce the utilization of other prescription pain managements. And this paper, published in the American Journal of Sports Pharmacy Benefits in 2017 by Louis McIntyre, again showed that if you use HAs over a 10-year period, you actually reduce the prescriptions for NSAIDs, intra-articular steroids, and opiates in the 6-month period pre and post injection of HAs. We actually, Biventus published a paper which looked at a 4-year care costs of patients getting hyaluronic acid. And again, this showed that the overall costs of treating patients when it comes to osteoarthritis was lowest in the population of people treated only with hyaluronic acid compared with those treated with corticosteroids or those progressing to knee arthroplasty. And interestingly, the use of opioids and other prescription analgesics was again lowest in that HA group compared with the corticosteroid group. This is just another paper that basically says the same thing, so I won't say that. And then in January of this year, Mo Bandari's group out of Toronto looked at the differentiating factors of all the intra-articular injectables available. And their conclusions, and again, this was actually sponsored by the people who make the long-acting steroid flexion, or Zilretta, it's called the product's called in the States. I'm not sure whether it's been launched in the UK yet. But they actually found that high molecular weight HA was the only treatment that they looked that passed the MCID for both pain and function outcomes, even over extended release corticosteroids. And interestingly, although plasma-rich, platelet-rich plasma, PRP, demonstrated beneficial effects, the results for that range from 0 to 100, so they couldn't identify them. And that's something that I think we found across the board, is the results on PRP vary incredibly. They can even vary in an individual, whether you take their plasma first thing in the morning or last thing at night. As you actually analyze it, they are very, very different. So the evidence on PRP, the jury's still really out. But ultimately, this paper was a level 1 systematic review of level 1 evidence and was published in Sports Traumatology and Arthroscopy in January of this year. Okay, and again, another study looking at the Osteoarthritis Initiative. This, again, a reminder, this is a multi-center observational cohort study. This looked at over 4,700 patients that were followed up over 9 years. And basically, they found that patients getting, with each intra-articular corticosteroid injection, it increased their risk of knee replacement by 9.4% at 9 years compared with those who did not get intra-articular corticosteroids. So out of those 4,796 patients, of the patients getting steroid, 31% progressed to knee replacement in that 9-year period. And in those that didn't get steroid, only 5%, so 152 out of over 3,000 actually went forward to knee replacement. And this has really been borne out by a number of papers that have been published in the last few years. Now, you know, I still remember my training from Charing Cross and my early clinical years in the early 80s, when we were all told that you don't put repeated doses of steroid into a joint unless you're going to replace it fairly soon anyway, or they only need it for an acute injury, because they damage the knee joint and other joints. And despite the fact that I think we've really all known that for years, they still get recommended. And I think it's partly because there's a lot of patient bodies that know that if you have steroid, you get better quickly and you can walk out of the clinic or you can play sports the next week. And those of us who've looked after sports teams know very well, we use a lot of steroid because the players want to get back, and we sort of deal with their problems when they retire or when they smoke too much and drink too much and can't play sports anymore. But this was a really nice paper that was published by which is the one I was going to look at. I was going to actually look at a paper that was published by Tim McCallendon, but that was published in JAMA in 2017. In this paper, they randomized people to get either 8 injections of triamcinolone over a 2-year period or 8 injections of saline over the same period of time for mild to moderate knee osteoarthritis. And interestingly, there was absolutely no difference between steroid and saline when it came to pain control. But what they did show was there was a much greater cartilage loss over that 2-year period in people who were getting intra-articular corticosteroids. Now, I don't think that's anything new, but it sort of gets ignored, I think, in clinical practice, that, you know, repeated doses of what is a cytotoxic thing into the joint is probably not a good idea on a long-term basis. And some of those recent guidelines have come out, have all said that steroids great short-term one-off, but as a repeated injection, especially in people in the early stages of the disease, then, you know, if they have an acute inflammation, acute effusion, and acute inflammatory process going on first time, by all means use a steroid, but then move to HA thereafter, and you'll probably do the patient a lot of favors. I am coming to the end of my time, and you'll be pleased that I don't have many slides left. One of the things that we're trying to do is to delay. We're never going to negate the need for knee replacement, but if we can delay that first knee replacement until somebody is in their mid to late 60s as opposed to their mid 50s, then we'll be doing patients a lot of favor. Knee replacements are not at the place where hip replacements are. This table here, the dotted blue line at the bottom shows revision hip arthroplasty, which is going down, and that's because primary hip arthroplasty lasts a lot longer. You know, those first Charnley hips, well, there's still people walking around with them, I believe. You know, they don't, knee replacements do not last as long as hip replacements. This data is based on a US population, but primary knee replacement is going up year on year. The data on some of my slides shows 730,000, but in 2019, there are over 900,000 knee replacements in the United States. But the worrying thing is that revision knee arthroplasty is going up a lot quicker. It's now estimated in the US population that over 50% of patients getting a primary knee replacement will have at least one revision done in their lifetime. Now, first of all, the cost of revision knee arthroplasty goes up exponentially. First knee arthroplasty in the States is around about $30,000. Second is $60,000. And the third one they get, second revision, is between $120,000 and $200,000. Extremely expensive. And the morbidity and mortality associated with it is high. But if we can just delay that first knee replacement to the point where they only need one, then I think we'll be doing all our patients a favor. And as I say, there've been a number of papers reporting this, that in large cohorts of patients that you can, if you're using HA in appropriate populations of patients, you can delay knee replacement by up to 7 years. So in summary, always glad when the summary comes around. You know, should we be reassessing our treatment of people with knee osteoarthritis? If we treat them at the appropriate time, there's a lot of evidence to show that by using hyaluronic acid in these people, after they've been on it a while, they can get away with maybe just one injection a year, and you can keep people going with that without the need for intra-articular steroids, and hopefully without the need for resorting to opiates and other painkillers. Just another note on that, no acute analgesic was ever designed to be taken 4 times a day, 3 times a day for years on end. They were all designed as short-term symptomatic relief while patients are in pain. And yet we have patients who are taking paracetamol 8 tablets a day, day on day, year on year. And of course, we all know the dangers of overdose of paracetamol. I remember particularly cases when I was working in A&E, people coming in with acute liver failure from taking a packet of paracetamol for a toothache. These are dangerous products, and we all know the dangers of NSAIDs when it comes to GI bleeds and cardiovascular and renal effects. So we should really be looking at ways of reducing the utilization of these and hopefully negating the need for opiates. And perhaps reducing the repeated use of intra-articular corticosteroids, maybe delaying the need for knee replacement, and perhaps move the non-surgical treatment of osteoarthritis away from the surgeon who's there to operate and back into, I believe, the primary care situation where these patients are being seen. A slide that I didn't show is the relationship between people with the metabolic syndrome and people with osteoarthritis. And as you're all aware, with the more elements of the metabolic syndrome you have, the greater the chance you have of getting osteoarthritis. So with that, I will stop talking. I've probably gone 5 minutes over my time, so I apologize, Eugene, and open up to any questions that you may have.
If you have a question, please unmute yourself, because most people muted themselves. So if you have a question, unmute yourself and raise your question.
I've either stunned you all into silence, or you're all having postprandial sleep.
I guess we postpone it until later on.
Okay.
Thank you very much, Peter. Then we move over to Andrew Harrison. Andy, please go ahead.
Indeed. Can you see the screen, Eugene?
Yes.
Excellent. Okay. So as a little bit background to me, so I'm a scientist. I have a PhD from Manchester on mesenchymal stem cell biology. I spent around 5 years at the Orthopaedic Hospital in Oswestry, working on a variety of things, before joining Smith & Nephew and working in their research centre in York for 18 years. And this is where I got introduced to hyaluronic acid. And as we'll see in a minute, I was deeply skeptical about hyaluronic acid and its effects. And then from 2013, we became working with Bioventus. And as many of you probably know, Bioventus is a spin-out of Smith & Nephew's Biologics division. And Smith & Nephew still own 49% of Bioventus. So tonight, as Peter's already alluded to, we're talking about hyaluronic acid. And this is a really simple but yet complicated molecule. As you can see here, I'm just going to bring up the laser pointer. There we go. It's made up of 2 alternating molecules here, N-acetylglucosamine and glucuronic acid. And that's the same no matter which species we're getting this from. So from humans to horses to chickens to bacteria, it's all identical. You can see here as well that this is one of the places that you find hyaluronan in the cartilage. And here you can find the bottle brush structures of the proteoglycans coming off here. I mean, my first job in science was raising monoclonal antibodies to this core protein. But again, hyaluronic acid is found throughout the body. It's found in your cartilage. It's found in skin. It's found in the eye. And then obviously, it's a major component of the... Oh, someone's come off mute. And it's a major component of the synovial fluid. Is what we're going to talk about tonight. Peter's already shown this, so I can move through this slide quite quickly. But what it shows is that the normal hyaluronic acid in your joint is around about 5,000 kilodaltons. And what we like to think is these first generation products, which are just purified hyaluronic acid and not modified in any way, have been the first treatments used in this area. And then a number of groups have modified their hyaluronic acid, whether it's Monovisc, Gel 1, Synvisc, and through different modification steps. And some of them increase their molecular weight, and some Monovisc still have a very low molecular weight, really. Gel 1 is a very complicated product where they actually gel the hyaluronic acid in the syringe. And again, as Peter said, that's a really difficult thing to understand what this molecular weight is. But as hopefully we'll be able to tell you tonight, that DUROLANE is very different. So you can see here that DUROLANE has a molecular weight of greater than 10 to the 12 kilodaltons. So we're in an absolutely massive molecular weight compared to everyone else. And what people will come and tell you when they come, your reps will come round and start talking about hyaluronic acid is, oh, mine is bigger than theirs, and theirs is bigger than this. And actually, the molecular weight of the hyaluronic acid that you buy has absolutely little effect on its half-life. Or the half-life is the time when half of the product is left in the joint. Now, to annoy Peter, this is extremely old paper, but it's still valid, actually. It's and why I show it is that it clearly shows this is half-life of two completely different hyaluronic acids. One at 6,000,000 kilodaltons, and one at 90,000, 90 kilodaltons. And this massive difference in molecular weight only equates to 3 hours in half-life. So the half-life has hardly any effect on the time that the hyaluronan stays in your joint. However, the size of the molecular weight of the hyaluronan does have effect on its clinical efficacy. And this is a study done by Roy Altman, but again, other people have done this. And they've shown that depending whether it's high molecular weight, low medium molecular weight, or low molecular weight, has effect on efficacy, as you can see in this here. You can see here, this side of the graph here favors hyaluronic acid, and this dotted line here is the minimum clinically important difference, or it's the difference that patients can actually detect, not just statistical difference in a clinical trial. And as you can see, these low molecular weights, which are greater or less than 1.5 million, they have an effect, but it doesn't break this minimum clinical important difference. The moderate, which again are between 1.5 million and 3 million, they straddle this line, and the high molecular weight clearly break that line, and that's greater than 3 million. And I can tell you, there's only 2 products in here, and that's Synvisc and DUROLANE. So the repeatability of these high molecular weight products have clear benefits in efficacy in clinical trials. Tonight, we're going to talk a little bit about DUROLANE and how it's different to the other HA products. And here are the indications and safety information for DUROLANE. And again, you can see, we can talk about this for a while, but it's available here in the UK for mild to moderate osteoarthritis of hip, knee, and again, for these ankle joints, shoulder, wrist, fingers, and toes. And also we do the small joint, SJ, which is a 1 ml formulation. But DUROLANE is very different from the other hyaluronic acid products because it uses this stabilizing technology known as NASHA. And all this is the ability to concentrate down the hyaluronic acid until the pieces of hyaluronic acid are incredibly close to each other. And then at that point, a small amount of covalent bond is put in there to hold it in that conformation. And the value of doing that by concentrating it down is that we can use very small amounts of crosslinker. So we're talking 0.5% to 1% crosslinker. Here is the crosslinker, BDDE. Here are 2 chains of hyaluronic acid. And now comparing that 1% of crosslinker to other products, you can see in other products there might be 5 or up to even 10% of crosslinker. That's because if it reacts with one of the molecules, it's got to find another HA molecule before it reacts with water. And therefore, a lot of these other products have wasted a lot of that crosslinker without actually being able to get it to bind to another HA molecule. Because DUROLANE is concentrated, it makes very high use of all its crosslinker, and therefore that's why it's been designed in this way. And the outcome of this is not a solution of hyaluronic acid, but instead it's a gel slurry of beads, hyaluronic acid solid beads. And the value of that is that it stays in the joint for a long time. And that is how DUROLANE has been designed. It's never been designed as anything else as a single injection hyaluronic acid molecule. And you can see this when you look at the half-life. So again, what I said before, the half-life is when 50% of the product remains in the knee. And here you can see this is unmodified hyaluronic acid in the orange. You can see it's got a half-life of around about 20 hours. This is actually Supartz. This is our product in the United States that Peter's just mentioned. Synvisc 1, that's got a slightly improved half-life, but that moves from 20 hours to around about 2 days. And then the DUROLANE in rabbits, again, it's a 32-day half-life. So it's an order of magnitude longer than any of these other products. And then when you look at the human situation, because, whoops, as we say, DUROLANE is the only HA of which we've actually established the residence time for in humans, we have it in 30 days. And you can see these graphs, and all this data is published. You can see that these graphs are overlying each other very consistently. And that is its key selling feature, that it's a single injection because it stays in the joint for much longer than other products. I'm quickly going to talk about 2 science studies, and this is the first one. This is a study we did with Professor Scheibler here. Professor Scheibler is a world-renowned pain biologist in Jena in Germany. And this study, published in Arthritis Research Therapy, uses a pain model. And what this is, we inject bradykinin and PGE2 into the joint space, followed by testing. The bradykinin will bind to the nerves, the nociceptors, and cause them to fire. This is a pain reaction. And the prostaglandin, the PGE2, will exacerbate this effect. So again, when a nerve will fire for a short amount of time on bradykinin, it'll fire for much longer when mixed with PGE2. PGE2 will also bring more nociceptors into the play, allowing bradykinin to bind them and bringing on hypersensitivity. What we do as well here, we inject on just this once, day 1 testing, day 1, a DUROLANE or a saline injection. And then the testing that we do, I'm only going to show you this one test, is looking here at mechanical stimulation. And what we've got here is a dynamometer, and this dynamometer is placed on the lateral joint line of this animal, and it's depressed, and a force is given to the lateral joint line, and the animal will tell you whether it's hurt because it will retract its leg or it will squeak, it will vocalize. And I think I should just point out that the maximum force I can give is 250 grams. When I look at the results coming out of this, we can see that actually in baseline testing, that 250 grams does not really register as a pain reaction in these animals. However, when we inject the saline and inject the bradykinin and PGE2 on each of these days, this threshold is reduced from around about 245 grams down to about 160, 170 grams. So this is essentially what the pain of mechanical stimulation is. It's like your patients who are walking, they can walk a few blocks, but then it starts to hurt. In comparison, and which completely took myself and Professor Scheibler's breath away, you can see the clear anti-nociceptive effect of DUROLANE. And again, this is right out to day 56. We only injected the DUROLANE here on day 1, but at day 56, it's almost as if that these animals cannot feel the pain. And again, myself and Professor Scheibler were completely stunned by this. Neither of us thought that this had happened. We thought if anything were going to happen, it'd take time to break down and then it'd have its effect. So, and again, he's now writing review articles on saying the benefits of HA in osteoarthritis pain. Another study that we did was with Professor Anna Plass. Anna here is a professor in Rush in Chicago, a world-renowned cartilage biologist. And this model is a model of osteoarthritis. And this model uses the injection of TGF-beta into the joint, separated by 2 days, and then a day later we inject the DUROLANE. And these animals are exercised vigorously at 32 centimeters a second uphill. And now with the running itself, that will not elicit an osteoarthritis phenotype. The TGF-beta itself will not elicit OA, but actually by combining the two, by having this stress growth factor, this reparative growth factor, and stressing the joints in combination gives a very typical osteoarthritis phenotype. And here you can see Jun. This is the process. One of the things I should actually state is that in all these experiments, we are present. We check the experiment is doing correctly and everything is being done as it should be. So Jun here is running the animals and we're looking at this. And a few months later, Professor Plass rang me up and said, it's really strange, but your animals do not limp. They run really, really well. And we went and checked and we could see them running really completely effortlessly. And the question was, how on earth do you measure that? And we measure it using this device. This is a tread scan device. What happens is the animal is placed in this little box here. There's a see-through tread here and a high-speed camera to pick up the gait analysis of the animals. And what we've got here is just the data we're going to show you is the walking or the stance time of the animal. Normal walking is at 1. And if I can actually overlay the animals, you can see that the animals start at 1, but their stance time increases over time. The reason for this is if the animal knows that its limb is painful, it's going to carefully place it on the treadmill. And therefore the stance time will increase over time. When you look at the DUROLANE animals, the animals start at 1 and they end at 1. There's no difference in their walking. They walk completely normal, even though they have been induced to develop osteoarthritis. And when you look at the histology, it becomes clear why. Because this is sagittal section through the knee joint, stained with safranol showing the cartilage and fast green showing the bone. Here you can see these 2 boxes here. These are these boxes here, just a higher magnification. In the OA group, the cartilage is all gone. In fact, here you can see the starting of an osteophyte forming. Here in the osteoarthritis in the saline treated, this joint is all misformed. All the back has fallen away here. If you look at the staining here, there's not much glycosaminoglycan protein stain there. Here in the DUROLANE, the joint is completely normal. The joint line is completely normal. And this is absolutely packed with glycosaminoglycan. So just as Peter said, DUROLANE is able to preserve the joint in these situations and protect it and allow the animal to ambulate. Again, all these images, not selected by myself, these are actually in the publication as selected by Professor Plass. Very quickly, I'm going to talk about just a couple of clinical studies that we have with DUROLANE. The first one is this one done at the Charité Institute in Berlin by Professor Perker. And again, it's a single center, prospective, open label study. We have 50 patients, and again, we've treated them with DUROLANE and with various outcome measures. And the really interesting thing about this is, like with many things, we can see that over a 24-week period, there's a significant reduction in pain. but not at the 2-week time point. So you can see this 25% reduction over 24 weeks, but at 2 weeks, the patients aren't perceiving and pain relief. However, when we look at the KOOS score, the activity score, knee outcome osteoarthritis score, you can see that even at the 2-week time points, the patient's activity levels are all increasing. So this is one of the key things that hyaluronic acid does. It allows the patients to get back their activity. And as you can see, over time, these scores increase over time. The other thing that this paper does is it very nicely shows us how the patients can get back their range of motion. If you look here, these are actually the patient's own score in trying to achieve their range of motion in their knee. You can see here before therapy, they're able to only get this much, and even 2 weeks after, not a lot more. However, at 24 weeks, the patient themselves is able to get a significant amount of range of motion back. Now, if you look at what the physiotherapist was able to do, at all these time points, the patient did have this range of motion. So this is the physiotherapy allowing and measuring themselves how much motion is in the joint. But at these time points, this is too painful for the patient to realize. Only at 24 weeks does the patient themselves able to get that significant increase in the amount of range of motion. And as we know, every degree counts, because it's always that concept of rising from a chair where the feet have to be placed behind the knee in order to give propulsion. The second study, again, a level 1 study. This is with Ross Layton. It's a level 1 multi-center, double-blind, randomized, active controlled trial with 442 patients from patients in Sweden, the UK, and in Canada. And what we've got here, we've got 2 phases. And the only reason I'm showing you this is that actually we have a lot of completers, which suggests that both patient groups were satisfied with their treatments. But then we did an open extension phase. So patients who had DUROLANE were open to receive a second injection of DUROLANE, and patients who were on the MPA, the methylprednisolone acetate, the steroid, they were open to receive an injection of DUROLANE. And so what we can see from the results is that the DUROLANE and the MPA, the steroid, both work very well in the short term. But then between 18 weeks and 26 weeks, there's a significant drop-off from baseline in the steroid group that is not seen in the DUROLANE group. However, when we do this second injection at the open extension label phase, we can see there's a significant improvement of responders. So this point here is significantly greater than this point here. And again, you can find this anecdotally through people who use long-term treatments of DUROLANE, saying how their patients seem to do better with the more applications of DUROLANE that they receive. The other thing to notice here is that those patients who had stopped responding to steroid, just like Peter said in this first talk, if you start reapplying that steroid, you're not going to have any effect. But these patients who have stopped responding to steroid can now respond again to DUROLANE, because DUROLANE is a different mechanism of action to the steroid, and therefore the patient is still able to respond to DUROLANE. And some patients decided who had DUROLANE didn't want a second injection. Only a small number of patients, but these on average had benefit out to 12 months. I'd say that these are outliers, and I'd say that most patients on their first injection would be only getting around about 6 months. But then in next injections, they get longer and longer. And hopefully we're going to publish some data on that very soon. My final study is the Mcgrath Study. And the Mcgrath Study, again, it's a study done here in the UK at the National Institute of Orthopaedics at Stanmore. And again, this is a study completely independent of Bioventus Smith & Nephew, Sanofi, or Genzyme. But it's a head-to-head study against DUROLANE versus Synvisc 1. And what I'm going to show you is that the key results here. So this is the VAS pain score in these patients. Again, just looking here, the Synvisc 1 and the DUROLANE. And the thing what I want you to take away is at the 3-month time point, both of these products are working. We can show a significant difference here, but really what we're looking at is Synvisc is working as well as DUROLANE. However, if you think what we talked about in the science and the half-life, you realize that the Synvisc is being removed from the joint faster than the DUROLANE. The DUROLANE has a significantly longer half-life than the joint. And as you can see, those patients with the Synvisc have reduced, but then have rebounded because the Synvisc has been gone from the joint and now it needs to be reapplied. However, with the DUROLANE, right through to 6 months, there's still a significant effect here. And the last slide, really, just for the Oxford knee scores, again, comparing the two different groups, you can see at the 3 months, remembering that the high numbers here are mild and the lower numbers are severe. So both products are working very well. In fact, you could say DUROLANE is even in the mild category, but only just sliding in there. But if you look at these Synvisc 1 data, you see it works very effectively at the 3 months time point, but as the Synvisc is removed from the joint, these patients end up where they were. The DUROLANE stays in the joint, has a good effect for 3 months, but again, because it hangs tough and stays in the joint, we're still in this mild to moderate phase at the 6 month time point. Again, there are other head-to-head studies, and again, they all show benefits of DUROLANE. But in the interest of time, and to let our guest speaker have longer to talk, I'll stop there and hopefully invite Graham to take on. Unless there are any burning questions. No, in that case, Graham, do you want to?
Okay, well, good evening, everyone, and thanks for staying with us. So far, everyone stays, so hopefully not everyone drops off now I talk. My first challenge is sharing the screen. So, let's get the right presentation. There we go. Okay, so I'm Graham Walsh. And I'm actually a knee surgeon, so it's interesting I'm here and we're talking about avoiding surgery. But you know, I think it is important, certainly particularly now with COVID, that we do consider ways of delaying surgery. I work up in Huddersfield and also kind of have a role in IT. So if it all goes wrong tonight, it's all my fault. So where is Huddersfield is the first question. Well, it's kind of a small town in the north, and this is a hospital where I work, which is Calder Royal. Now, what's the problem? We know the problem we've been talking about all night, osteoarthritis. It's a significant impact on populations worldwide. A significant amount of adults will develop osteoarthritis as they grow older, and ultimately, joint replacement is where most of these people would end up, and it's our kind of role to try and find ways of delaying that to a point where patients can function without the need. DUROLANE is that solution, and we will touch on that tonight, but I'll go over a kind of ways we can manage osteoarthritis without surgery, which again is probably quite alien for a surgeon to talk about. So what are the treatment options? Well, we all know there's walking aids, there's physical therapy, there's lots of injections. We've talked about steroids, we've talked about hyaluronic acid tonight, and we've even touched on PRP. We can do conservative measures with arthroscopy, where we can do various techniques to try and delay the need for a joint replacement. Osteotomies, they're growing in kind of trendiness, if you like. A lot more people are doing them, and this is, again, it's a way of deferring the need for a joint replacement. But really, kind of, I suppose, any of the treatment options we consider really depend on the Kellgren-Lawrence scale. And really, that's kind of where we go to with DUROLANE as well, because, you know, DUROLANE is not going to cure all knee pains. It's going to cure those in a certain area. So why has COVID changed what we do? Well, we certainly have a huge reduction in capacity for surgery. This is not only because, I mean, in my own practice, you know, we took about a 6-month period off elective operating, and we have patients therefore waiting much, you know, well over a year now for surgery. Patients are fearing COVID, and they are cancelling operations because, you know, of the risks post-operatively. We need to kind of empower patients to better self-manage themselves, particularly we need to keep them out of the hospital setting if we can. Longer waiting lists mean that patients are waiting longer, and therefore, while they're on the waiting list, we have to consider ways of managing their pain. And we know now that traditional methods may pose a risk. We've talked about steroids a lot tonight, but giving steroids in the setting of COVID, that in itself does carry with it a risk. Giving a steroid does transiently lower the immune system for the patient for a period of time, and therefore, you know, although it's, you know, we are now able to administer steroid injections, they are advised to be at a lower dose and to be strongly risk assessed, whereas DUROLANE and other hyaluronic acid type injections don't have that risk associated. So that's something to consider as well. So the Kellgren-Lawrence, we've talked about it a lot. What's it really mean? Well, essentially, you know, it's 1 through 4. Most patients in 1 will have very little symptoms. Most patients at 4 will be considering joint replacements. So, you know, at stage 1, you see very little on the X-ray, and at arthroscopy, again, you see very little. You see a relatively normal joint surface and a meniscus in the background. When you get to level 2, you start to see more changes on the joint surface. The chondral tissue begins to break off. You may get meniscal pathology, and you may begin to see some changes on the X-ray of some sclerotic margins, some cysts and forming. And as you get to 3, the chondral tissue starts to break off. You start to get more mechanical symptoms. These patients will have concurrent meniscal pathology as well. And again, at this stage, you can start identifying the changes on X-ray. And then you get to 4, and clearly at 4, the bone is exposed, the joint surface is denuded of any cartilage, and these patients really do complain of significant pain, and radiologically, you can see the changes. So one of the things we need to do is consider ways of managing pain in the patients, because as Peter said earlier, it's the end point is pain relief. How we get there is not important, whether that's through a joint replacement or injections. You know, we just need to give the patients the best quality of life we can. And the step care model was something that was born out of a consensus group in Europe, the ESCO, and they produced an algorithm back in 2014. So sorry, Peter, this is quite an old paper. And, you know, and they looked through various clinical trials, and they developed a kind of a stepwise algorithm for managing osteoarthritis without the need for surgery. And this is kind of in a nutshell. Essentially, there's 3 steps, probably 3.5, because the first step essentially banks on the patient doing something for themselves. And I'm just going to briefly go through these in turn, because I appreciate time's getting on, and we've got a few clinical cases to discuss. So symptomatic. Well, the first thing is, we all know if your patient loses weight, it's going to make a big difference. You know, and studies in particular in this paper showed that a significant amount of weight loss can reduce pain significantly. Physiotherapy and exercise is also really important to get the patients back to where they need to be. The next step is to consider the kind of the simple stuff, physiotherapy. You know, we don't use them as much now, but braces can be helpful in younger patients to offset the load on the joint. Insoles, there's very poor evidence, but certainly I believe there's some podiatrists on the call tonight, and they do help. You know, they help to change the mechanical alignment of the joint and offset the load and make the patient feel better. Taping is something I use a lot. The evidence is very mixed, but it really does help, and that's the K-taping, and we use use that both in our patients that have had surgery and those before surgery, and treatments such as acupuncture and TENS can be helpful. We've touched on taking regular analgesics, and it was interesting that Peter talked about paracetamol overdose. It's not a safe drug. We give it a lot. You can buy it for 19p at Tesco's, but it is a drug if taken regularly can cause problems, and beyond 3 grams a day, it has been shown to be quite harmful to patients. Some of the chondroitin and glucosamine has been shown to be helpful in a higher dose, and for patients it's worth them taking that, because anecdotally and certainly evidentially patients can get some improvement. And topical steroids in this particular group was just as good as the oral steroids, so it's worth recommending that to patients as well. But once you kind of step beyond this, the pains continue to move, and this is where we kind of at really now. You've got to consider the oral non-steroidals. They're harmful. They can have both GI and cardiac ramifications, and it's they're not drugs that patients should be taking long term. But this is where the paper's been really helpful. It recommends that hyaluronic acid is just as good as non-steroidals to both treat pain and delay the need for joint replacements. Corticosteroids, again, useful, short-term effect. We all know they work really quickly. We all know the side effects with regard to hastening the need for a joint replacement, damaging the joint surface. But I think in this current climate, we have to really consider the potential immunosuppression with COVID, and the patient group we're probably giving these to are in a higher risk group for COVID, and it's probably something that we should really avoid, and therefore hyaluronic acid of those 2 injections appears to be the best option for your patients. What's the role? Well, we know it's effective for OA. We've heard lots of papers tonight. There's a huge amount of studies now that have proven that. The effects can be long standing. It takes at least 4 weeks to hit its peak, and therefore the effects don't start to wane till after about 2 months after the injection. And really, in certainly the patient groups that we see, normally it's between the 6 to 8 month stage where the patients are coming back and thinking about having further injections. And I think one of the really important studies is that it has been shown to reduce the need for joint replacement by about 3.6 years in the study by Altman, and that's really important, particularly on what we're discussing tonight is the need to delay joint replacement. So it's a really useful adjunct to our treatment. There's lots of studies, and I've been over these, and this is just really a summary slide of some of those. But essentially, what these studies show is that hyaluronic acid and DUROLANE, they work. They're a pain relieving injection, and it is effective, and it's something that we should consider. I think when these injections first came out, and I don't think there was any secret that they would just be used for every patient, patients with KL4, and in those patients it wasn't effective, so they probably initially got a bad press, and then it wasn't helped with obviously the NICE guidelines recommending not to give these based purely on cost, not really on any science or clinical studies. And this again is a chart of a summary of some of the studies. It's not up to date. There are some newer studies on there which really do kind of point to DUROLANE as something that we really should be considering in our patients. So when do I give DUROLANE? Well, I think one of the important things is if it's in a younger patient with the grade 2-3 changes, there's no real point giving it if the patients have mechanical symptoms. So if you've got a patient with, a rather obvious acute meniscal flare, these might need to be addressed with surgery first. So you might need to address the mechanical problem, following which you could administer the DUROLANE. So say you have a patient with a grade 3 or grade 2 change in the knee, they're going to have pain and mechanical symptoms, address the mechanical symptoms with arthroscopy, and then use the DUROLANE to address the pain symptoms that I have. I think one of the real keys for this is to make the patients be aware that you're not curing their arthritis. You're making their arthritis feel better. You're giving them relief from some of the pain. So what I like to think of it is if you have a patient, for example, who may on the pain score see a pain level of 7 as a reason for having a joint replacement, the DUROLANE may get them to a 5 or a 4, but that's enough to get them below the threshold where in their mind they want some surgery. So that's something to consider when you're treating patients, and to let the patients know it might not get rid of all the pain, but it's going to get rid of most of the pain that's making them want further treatment. I think it was mentioned earlier that there's no point giving these injections when you have an inflamed joint, a joint with an effusion, a joint post-operatively that has inflammation, because they will probably cause a flare of that inflammation. In that setting, giving a steroid to reduce the inflammation or aspirating the joint is probably more useful. It can be useful in athletes recovering from knee injury. And again, in the younger patient, it's a really useful tool to delay the need for joint replacements. So how do I give DUROLANE? Well, I give it in the clinic setting. We don't take them to theatre. You can give it with ultrasound, but around the knee, it's certainly ultrasound is not necessary, but in other joints, ultrasound or image guided can be useful. You obviously use an aseptic technique. I'll mention later that occasionally you can give it in patients with unicompartmental knee replacements, and in those patients you probably should be doing it in a theatre setting. I always use a superlateral approach, and I know there's 101 different ways of injecting the knee, but superlaterally it's a really safe corridor, it's really easy to inject, and you're not going to risk injecting it into the soft tissues. One of the problems with injecting through the medial lateral aspect of the knee around the joint line is that you can inject into the fat pad, you can inject into the ACL, you can inject into the meniscus, and you can cause damage to the joint. And I think it's really, if the superlaterally, you know, when you do arthroscopy, there's nothing there. And I think this way you can avert the patella by putting slight pressure on the medial aspect of the patella. And the other key is to only inject if there's no resistance. You know, time and time again, I hear from patients how they had an injection and it was really painful, but it didn't work afterwards. You know, and that's, you know, this is one of the issues that we have with injections sometimes in primary care. If you inject against resistance or if the patient's in pain, you're not injecting into the joint, you're injecting into the soft tissue. So it's important not to continue to inject. And that's a really kind of important tool. And injections should not be painful. So what do you tell the patients? Well, the key, make sure they're aware it's not going to cure their knee pain completely. It's going to improve their knee scar. It's going to improve their knee pain, but it won't make all the pain go away. So it's important to give that information to the patient, because you don't want them to go away and think the injection wasn't a success. Tell them that they're going to experience pain. Whenever I give an injection of DUROLANE, normally for a few days afterwards, they get a flare of discomfort. And that's probably the injection, you know, it's inflammatory effect that it has initially, and it's important the patients recognize that, so they're not ringing you up or ringing the nursing staff on the ward up to say that they've got an infection, or even go to A&E and have an aspiration of the DUROLANE you've just put in there to see if they've got an infection. The effects can last for many months, and I think it's important to let them know that it's a gradual effect. It doesn't happen overnight. It's not a magic wand. It's, you know, if the patient's had a previous steroid injection, they know that works. You know, you give it in the clinic, by the time they get to the car, the pain's gone. DUROLANE works slower. It takes about 4 weeks to have that initial effect, but when it comes on, it lasts a lot longer. And I think the other thing I tend to tell patients is to kind of avoid vigorous activity for a few days. They can go to the gym, but not to go too hard, because again, that can cause a flare of discomfort. And going back to the study earlier, you know, the last stage beyond DUROLANE is opioids. We've heard already how dangerous they are. We know we shouldn't be giving them, and really we probably should avoid opiates. There is kind of some thought about antidepressants desensitizing, having a central effect, and that has been shown to improve some of the pain in osteoarthritis. So before you get to surgery, as I say, these are the options. But the end stage probably is going to end up being a joint replacement, but it should not be the first choice. It carries risks. The complications certainly at the moment around basically offering surgery, delivering surgery. We have theatres now that are used for other reasons. We have theatre staff that are deployed to other areas. We have the risks associated with green pathways, and so doing surgery is a complicated, has been further complicated by COVID, and patients are certainly wanting to avoid that. So I think now DUROLANE is really an important tool. It can, interestingly, you know, I'm talking about sometimes using DUROLANE to help people on the waiting list because of the prolonged waiting list. That's not something you'd want to do with a steroid, because a steroid does risk infection in the joint replacement when you come to doing the surgery. DUROLANE's less, it has less of that risk, and therefore it is a useful thing that you can give a patient on a waiting list if they're now going to be waiting. I have patients, unfortunately, might be waiting over 2 years for a joint replacement, you know, and they're going to be waiting for 2 years in pain. So giving them DUROLANE will both safely allow them to, you know, to have pain relief while they wait. And I think one of the things we've talked about avoiding joint replacement, and you know, just this really, these slides are really for interest. I think a paper back in 2010, which again will upset Peter, but he's here for a reason. You know, David Bevelin did, you know, a really important study where he showed that although hips, patients are really happy, with knees, patients are not as happy, and there's a high level of dissatisfaction. And in some studies, they're putting that between sort of 15 to 20% of patients are unsatisfied with any replacement post-operatively. Interestingly, now, we think as surgeons we're so much better. We think that implants are so much better, and we think techniques are so much better, and our patients are really happy, and they all are. But now that the National Joint Registry actually publishes PROMS data, it's really interesting that the latest PROMS data you look at pretty much echo what that paper said some 10 years ago. Even with all the changes we've done, patients still are not 100% happy with a joint replacement. And again, you know, the level of kind of fair to poor is probably at the 15 to 20% mark. So with all the advances we've done, we haven't really improved outcome from joint replacement. And that's something to consider, you know, and patients, it's something to mention to patients as well, because patients might not want to go ahead with surgery if they know that's you know, they're going to end up being less than satisfied. So we're coming close to the end, so I just wanted to go over a few clinical cases. And, you know, this is where you might consider DUROLANE, you know, just a few varied kind of things. You know, one of the most typical patients we see for DUROLANE is, you know, I'm going to say the 33-year-old female. It's not always a 33-year-old female, but it's patients with anterior knee pain. And it's a really common presentation. Now, if that patient, and this particular patient, had mechanical symptoms, their knee was giving way on stairs, they were feeling uncomfortable. Their x-ray was essentially normal, and the MRI scan shows some loose condyle flaps under the patella, and they had a relatively common diagnosis of osteochondritis. The first step was to refer to physio. Strengthening up the quads, offsetting the load would certainly help. Unfortunately, because of the irritability of the joint, physio didn't do very well and aggravated the symptoms. So the next step was to get, as we talked about earlier, to get rid of the mechanical symptoms. And in this patient, we carried out an arthroscopy to debride the soft tissues, the cartilage. And then the patient felt better, but they still had some degree of pain. And these patients do really well. So any patient with anterior knee pain that you've got rid of the mechanical symptoms, give them a DUROLANE, they feel so much better. It's this anterior knee pain that certainly has been a real bane in surgical practice, and people have often written these patients off. But DUROLANE is really helpful in these patients. And this particular lady got back to doing the sports, got back to normal. Another very typical patient we'll see is the kind of the I'm getting a bit older now, so 55 maybe isn't that old anymore. You know, the active 55-year-old, the active middle-aged patient who plays sports regularly, have mild discomfort, have a injury where suddenly the discomfort is exacerbated with mechanical symptoms. They suddenly get giving way and they suddenly get locking. The x-ray shows some slight loss of joint height, and an MRI scan taken particularly on this patient would show a grade 2 changes with a meniscal tear. So you've got to assume that the meniscal tear seen on the left may be responsible for some of the mechanical symptoms. So the first step is to debride that, clean the joint up, but the patient is then in a position where although the mechanical symptoms have gone, they've still got pain. And therefore, DUROLANE in these patients is really beneficial, and it can give them significant pain relief. And this particular patient actually got 9 months of relief from the DUROLANE. And, you know, the next type of patient is people who, again, very active, have an injury that brings them to the hospital, and at that stage, you know, they suddenly declare their pain. They might have put up with it for a long time, but you know, once they declare the pain, they're in a position where they should be treated. X-ray shows some evidence of lateral compartment wear. This patient wasn't ready to consider a joint replacement, but they were very active. So they, again, had a DUROLANE. I think they had about 2 injections before eventually I succumbed and we did a lateral partial knee replacement. Patient was satisfied with both the injection and the surgery. But again, these are the typical patients that really do benefit, and sports patient are another, we've talked about the kind of the viscosity, and it can be very helpful in athletes, not your typical reason to give it, but that cushioning effect can be beneficial. And there was one particular player came to see me before a game. I gave them a DUROLANE a few days before. They were unable to train, but managed to get back to professional sport on the Saturday and felt a lot better. They felt there was a cushioning effect. Whether that was, a true cushioning effect or whether it was the either way, the patient managed to play sport. And I think the final case is patients who are too unwell for knee surgery. And I think we've got to consider these, although we've kind of gone on a lot to say that it's not very good for grade 4 changes. It can be beneficial if you have a patient with such significant medical comorbidities that surgery is a risk. And in these patients, it will not cure them. It will make them feel better. It will give them a slightly freer degree of movement. And this patient, even given the level of wear they had, felt the improvement with the injection and got to a point where they were able to get on without having to consider a risky operation. And just one final patient is, this is a patient who, who kind of expanded the indications in a way. This was a patient who partial knee replacement about 7 years before. They started to develop anterior knee pain. It was beginning to affect what they wanted to do. The X-ray didn't show any significant issues with the prosthesis. And in this patient, I injected DUROLANE, and they got relief. It got rid of the anterior knee pain, allowed them to get back to the kind of the post-operative stage where they were pain-free. So I think that is a whistle-stop tour, and I think we've done it hopefully enough time where we can have any questions.
Yes, very nice, Valentine. Thank you, Mr. Walsh.
There we go.
Then we open up for questions to either Mr. Walsh or the other speakers, Peter Shaw or Andy Harrison. If you would like to raise a question, please unmute yourself.
Hello. Hi, it's Koyo Editola here. I'm a hip and knee surgeon from Western-super-Mare. I feel like I've gate crashed a knee party, actually, being predominantly hips. But I wondered if I might ask a question about the clinical experience and evidence behind the use of DUROLANE in hips, possibly. Now, a year ago, I may not have asked this question because we had a pretty good solution that we could use in most patients. But in the COVID era, we are looking for alternatives for all the reasons that both Graham and Peter have mentioned. And we just need to find alternatives. Can we use DUROLANE in hips? Is there much experience of it? And is there much evidence behind it?
So I can speak from an anecdotal perspective, and I'm sure Andrew can speak from a scientific perspective. It was interesting because we used to run a course in Sweden, and we had a speaker from Barcelona who used to come and join us. And in Barcelona, there was a huge waiting time for hip surgery, and I think it was 2.5 years. And they injected a lot of their osteoarthritic hips with DUROLANE, and symptomatically, certainly anecdotally, the patients did incredibly well. And I think they did write a paper, and they showed both a pain relief, but also a massive economic benefit. So certainly there is a good anecdotal, but I think I'll probably bow to Andy, who's probably got a range of papers to support that.
It's an interesting one. I'm off mute. So I think in general, when we look across the board on HA for hips, it's probably not the greatest joint. And I don't know if Peter wants to build on that. But actually, we do have a couple of papers. We have the Per Berg paper, which shows some good outcomes. And again, if you email someone, we're sure we can get these papers to you. And we have Thierry Conrosier's paper that shows benefits. I think again, I'm a scientist, so I'm going to defer to the clinicians here. But I think one of the big challenges in hip injections of DUROLANE is actually accurately delivering it to the joint. I think it's quite a challenge. So I think when you look across the board, as I say, there isn't a lot of great data across all HAs, but we do have 2 papers that show its benefits. So again, if you want to have them, just let us know and we'll hopefully be able to get them to you. Do you have anything to add, Peter?
Not a lot. I mean, you covered most of it between you. I mean, there's certainly some evidence that if you get it in the right place, it works. The problem, as Andy has pointed out, is that that's not always the case. Interestingly, all the major large-scale studies in OA, hip, and with hyaluronic acid have all failed, the big ones. The Sinvis study failed, and various other ones have all failed. I think we're partly to blame for that. Is these studies are extremely expensive to conduct. You know, a phase 3 study for, you know, just a phase 3 study that we're looking at to do in OA ankle starts at 15 million. And there is a lot of pressure from above to get these things done quickly. Because the sooner you get the indication, the sooner you start to make some of the money back, and which then puts pressure on people recruiting the wrong type of patients. OA shoulder is a classic example. If you use hyaluronic acid in people with pure glenohumeral OA, it works amazingly well. The problem is that most patients with shoulder problems have a bit of impingement syndrome, a bit of adhesive capsulitis, et cetera, and in those people, you haven't got the volume to do any good, and they don't work. So again, in shoulder, it works really, really well, but you have to really pick and choose the patients. Shoulders, I think, are a lot easier. I always found them a lot easier to inject than hips. And hips really have to be done under some type of control. You will get benefit, choose the patients well, and you'll find good results.
Thank you. Are there any other questions from the participants? If you have a question, please unmute yourself.
I want to clarify my point about recent clinical papers. You know, when we work in the pharmaceutical industry compared with clinical practice, we're always told that everything we use is too old or whatever. And I, you know, there's papers going back on hyaluronic acid since, you know, we were all in diapers, nappies, sorry. I've been accused recently of doing that. So I tried to make everything as up to date as possible. And part of the reason for that is, of course, at Toby, I was competing with people who were talking on PRP and mesenchymal stem cells and adipose cells and things where, you know, the data is 5 minutes old and none of it's very good. So what I wanted to do is to really concentrate on very recent papers to try and you know, increase the credibility. I think HAs have been maligned for a long time, and I think if we were to relook at them with new eyes, we would see them in a very, very different light.
I'd like to just bring up something that Graham said, actually, and I don't know if everyone's opinion is of this, but it's interesting you said about the anterior knee pain in patients. And I met a group of surgeons a couple of years ago now, and they were telling me that how total knee replacement in this group of patients was that people were very unsatisfied with it, and and they were getting to the group in Grantham, and they said they had anterior knee pain patients, and they'd stopped putting total knee replacements in because they were absolutely sick to the back teeth of people coming back and complaining that they hadn't worked. So I'm really interested at what your experience of that is, and the fact that you seem to get really good results from anterior knee pain patients.
But I think the problem with anterior knee pain, it's an umbrella term that everyone just kind of defines. The majority of these patients have some degree of patellar maltracking, some, you know, trochlear, the morphology is very different. And I think when you just put a conventional joint replacement in, we're not considering that, patients will do badly because the patella, when you're not realigning that patellofemoral mechanism. And that's where taping can be very useful. Taping puts, almost gives the patients the feeling of the knee being in the, or the patella being in the right place, and they instantly has a real decent effect on anterior knee pain. But they are a difficult group, and I think we're trying to treat them with conventional means when essentially that they mechanically they are not like the rest. They're on a spectrum, not on a spectrum, in the nicest way. They're one extreme to the spectrum, and therefore when we do joint replacements, and it's interesting, I use a much more I use an attune joint replacement, which is a much more high functioning joint, and you're able, and it has kind of different shapes to the patella that you replace, and patients seem to be a lot better when you can, you consider the patellofemoral joint as a different joint, and and balance that and do the right thing. But it's a difficult problem.
So I'd like to thank the speakers for their interesting presentations and the participants for their contribution and participation tonight. If you have still questions that pop up later, maybe, please reach out to your Bioventus representative. You can also contact the Bioventus Academy. For that, you can use the link on the invite for today's webinar. And with that, we close the meeting. Thank you all again, and I wish you a good night.